I established many bench-to-bedside tests in the department, like BCR-able, PML-RARA, then EGFR testing, then I did the EBV testing, then I started with the DPYD, that is one of the pharmacogenomic anti-metabolizing enzymes, which is being used in 5-fludarabine. Sanger sequencing was very much useful because various exonic mutations are there where I had to look at each exonic mutation, and that helped in the Sanger sequencing. And today, before starting the 5-fludarabine to the patient, the test has been sent to the department to check whether the DPYD mutation is homozygous or heterozygous mutant. Not only the EGFR, then we came up with the KRAS, EML4ALK, RET, ROS, PIK3CA, then AKT mutations, but all this together I could design the 10 gene panel based on the fragment analysis called as also the snapshot on the Sanger sequencing. Single gene PCR, like for the digital PCR, where you can have a single gene marker and you can monitor it. The rare mutations, then again we have to go back on the Sanger, we need to validate that whether really it's a true mutation, and if it is a true mutation, we have to come back to the qPCR or the digital PCR, what is the copy number of that mutation present. So actually I can say they are complementary to each other. Absolute quantification, I think there the digital PCR is very useful, and I will appreciate for that less than 1% also if you get on the digital PCR, it should be appreciable, and we should take it as a true positive. This paradigm shift from chemotherapy to personalized medicine, earlier it was one size fits all, but it is not that, it is one size fits one. As a custom made tailor panel you have to design, and that is why the precision medicine is becoming more and more popular. If there are some metastatic in the patient, or there is some accumulation of the ascitic fluid or for that pericardial fluid, there also this fluid is, you can do the cfDNA extraction in this other body fluids, saliva, urine. So there also it becomes very important. If we concentrate on these technologies for the non-invasive procedure in the liquid biopsy, it's going to be very useful for the patients. PD1 or PDL1, that is a programmed death ligand markers, and for that matter you can get to see the CTLA4, that is the T cell receptor markers. If we identify them at earliest, where we are looking as a gene expression, clinicians are looking for whether how we can have a combination of this chemo plus IO, chemo plus TKI, or the TKI plus IO therapy, and how with early they have been treated at the stage 1 or stage 2, and along with that how we can reduce the toxicity. Applied Biosystem has really a definite role. It has an end-to-end solution for that. There was a very strong support for the Applied Biosystem from the engineer side. I think it has been a really milestones of the Thermo Fisher to reach to a very high throughput technology.